Good afternoon. My name is Felix Camposano, and my presentation today is to provide you an overview of the Ontario's health-based allocation funding. The presentation will focus more in Ontario around the healthcare funding. And before we start, I would like to thank the Board of Directors of Accreditation Canada for giving the opportunity to give you a short synopsis of this presentation. So the topic for today is around what is I'll give you an overview of the Canadian healthcare funding, what is the role of the government in providing funding from the hospitals, from the government to the Ministry of Health and Long-Term Care. So basically all Canadian provinces are responsible for managing the healthcare services of Canadian residents, and the federal government will assist in co-financing some of the healthcare programs as dictated by the Canada Health Act. Reforms have been made over the past 4 decades and will continue in response for changes within medicine and throughout the society. The basic, however, remains the same: universal coverage for medically necessary healthcare services to be provided on the basis of need rather than the ability to pay. Canada's publicly funded healthcare system is best described as an interlocking set of the 10 provincial and 3 territorial health insurance plans, known to Canadians as the Medicare. The system provides an access to universal, comprehensive coverage for medically necessary hospital and physician services. So my next topic that I'm going to talk about is how is the funding or the financing of the Canadian healthcare system. Normally, it comes through. It's through general taxation. The financing of the Canadian healthcare system is managed through the federal government, which contributes 20% of the provincial funding, and of course there are some challenges and continual tensions between the provinces and the federal government. According to Health Canada, 50% of the provincial expenditures is allocated to health services among provinces. So health is now approximately 50% of provincial expenditures. Under this healthcare coverage for Canadian residents, the Canada Health Act, which is a federal legislation, publicly funded the healthcare insurance. The Act sets out as the primary objective of Canadian healthcare policy, which is to protect, promote, and restore the physical, mental well-being of residents of Canada, and to facilitate a reasonable access to health services without financial or other barriers. The Canada Health Act establishes the criteria and conditions related to insured health services and extended healthcare services that the provinces and territories must fulfill to receive the full federal cash contribution under the Canada Health Transfer. Each province establishes a healthcare coverage and may vary from province to province. The federal government does not provide national benefit package, for this is a responsibility delegated to the provinces. So the next slides will talk about how healthcare is organized in Canada. Many Canadian provinces have regionalized healthcare system, a regional entity funded by the province. The provinces are responsible for funding. In Ontario specifically, the provinces are responsible for funding the local health integration network, and the expectation by the ministry to each health services provider, such as hospital, long-term care, CCAC, are accountability, transparency, efficiency, and patient outcome. An accountability agreement is signed at the beginning of the fiscal year, and the goal is to balance budget towards the end of the fiscal year. The CEO of the hospital and the board of directors are required to sign this agreement. In terms of how physicians are getting paid in the healthcare funding, or does this come? Physicians are directly funded by the provinces. They are predominantly a fee-for-service funding. That would include the primary care physicians, the specialists in most of the provinces. A number of provinces have implemented an alternative method of funding. There are some that would include from a common alternative is through capitation system, in which the physician is paid on a salary to provide a care to defined group of patients under his or her care. There is also the blended capitation payment scheme, which are used mostly by family physicians or family health networks. And these systems have a roster of registered patients, and the main payment is via capitation. The physician receives a base payment for each enrolled patient. This payment is adjusted to age and sex of the patients. Now, in this coming fiscal year, April 2014, the Ontario government, the Ministry of Health and Long-Term Care, will implement what they call it the Ontario's health-based allocation funding model. This is a Made in Ontario model. It provides an organizational level of allocations informed by case mix utilization, aggregate cost, volume, and type of patient and providers. So this would really help to look at the volumes of how each hospital manages its cases. In this particular model, they've also will be looking at, they call it the quality-based procedures, which are cluster of patients with clinical-related diagnosis or treatment that have been identified by an evidence-based framework as providing opportunity for process improvement, clinical redesign, improved patient outcomes, enhance patient experience, and potential cost saving. So what will be coming in the next little while, in the next in April 1st, is this new model. So the Ministry of Health and Long-Term Care is moving away from the global funding to what they call the patient-based funding, which is the HBOM for short. A significant focus of the Ontario Government Action Plan for Healthcare is to reform the funding system and to move towards a patient-centered system and away from a provider service model. In the past, the hospital received funding from the number of sources, the largest of which was the global-based budget. Others included such things as emergency room performance fund, growth funding, wait times, cancer care Ontario funding, and the Ontario Health Insurance Plan technical fees. But as of April 1st, this will all change. Well, there are some limitations. Historically, in terms of global funding, there are some limitations. Basically, the hospital will receive a lump sum of money for that particular fiscal year, but it does not take into account the complexity of all the patients that they see. It doesn't reflect the level and the costs of each service, and it does not provide incentive for process improvement or anything around efficiency, transparency, and efficiency of running a healthcare hospital. In April 2014, the funding will change significantly in terms of they will be moving away from the global funding, so that the global funding is going to be allocated for 30%, and 40% of this will be allocated to called the HBOM, or the patient-based funding, which comprise of like 40% will be based on those funding systems. So as you can see from this model, the patient-based funding for 2014 to 2015 will increase to 70%, and the global funding will be reduced to 30%, as indicated the Ministry of Health and Long-Term Care. This particular funding model has two components: the quality-based procedure and the patient-centered based funding. The HBOM is based on direct measures of health status, and it will take into account population-based factors such as age, gender, socioeconomic structure, rural geography, and patient flow. As health services provider, characteristics such as specialization, rural geography, and economies of scale. In terms of the quality-based quality procedure funding, actually right now, as of April when last year, or 2 years ago, they've implemented 4 major procedures, 4 quality-based procedures that will go into this model. The first one is the hip replacement, the knee replacement, dialysis, and other treatments for chronic kidney disease. And also one is the cataract surgery. So that would be based on cases, on weights, on volumes, and then there is a formula on how to allocate those resources. So as I said earlier, that the HBOM will be leveraged to provide an organization-wide level allocation informed by case mix utilization, aggregate costs, the volumes, and the type of patients that comes into the hospitals. So I think in terms of the health-based allocation model, it is a population health-based funding, and it is also a management tool which provides decision makers with actionable information and supports the strategic alignment of funding within management decisions. So with this model, there are 2 components to it. The utilization model, which estimate the use of the hospital services, taking into account the clinical, social, and demographic condition, and also the cost model, which determines the cost for each health service provider. So when the Ministry of Health put this together, they did a stakeholders analysis on how this will impact and what are the benefits of this model. It ensures that every community are funded according to evidence-based formula that reflects community share of the budget limit. It also helps addresses the unique local priorities and healthcare requirements. So that's why this particular tool can assess the extent of health sector integration by clinical programs and will provide a mechanism to reward high quality of care and operational efficiency. So this particular funding model is not new. It actually, in 1992, it's actually started in Sweden, and Australia followed next, and several countries have gone through it. Have actually experienced this type of model, and they get a lot of feedback in terms of the number of procedures that have gone up, the wait times has shortened, and the quality of care has improved significantly. So follow that up, France, Germany, and recently in 2010, British Columbia and Alberta have actually used this funding model. So basically, in closing up my presentation, the Ministry of Health and Long-Term Care have adopted this measure to implement and phase in the health-based allocation model. Now, what the hospital funding will be, it will be based on how many patients they look after, the services they deliver, the evidence-based quality of those services, and the specific needs of population they serve. So basically, that is what will be coming up in terms of the healthcare funding in Ontario in April 1st, 2014. So I think that would conclude my presentation, and thank you very much for inviting me to this meeting. And I will open the questions to the floor. Thank you.